Good evening, all of you. Good evening, all of you. Today, I, on behalf of SOCHAM, welcome you all to this second day of Neuro Health Days, which we are doing in association with Narayana Health. As you all know, last day we conducted a session which was so quintessential to all of us, and it had so much of knowledge even to a layman as well. Carrying this forward for the second day as well, now we have on our board Dr. Ashish Srivastava, Dr. Amit Srivastava, and Dr. Neha as a moderator. To just give a brief about Dr. Neha Agarwal, I'd just like to give a few words about her. Dr. Neha Agarwal is a senior consultant anesthesia and head of quality Narayana Health North Region. She has over 25 years of clinical experience in anesthesia. She is an ex-HOD of Department of Anesthesia and Critical Care at Dharamshila Narayana Super Specialty Hospital. She has also to her profile a degree of MBA in Healthcare Administration from Faculty of Management Studies, Delhi University, PGDHHM from IGNOU, postgraduate in Quality Management and Accreditation of Healthcare Organization from Academy of Hospital Administration, NABH assessor since August 2009, and AHA certified ACLS instructor. Now, please welcome Dr. Neha to take the lead and carry this forward. Dr. Neha, over to you, please. Thank you.
Thank you, Ms. Pyle, for the introduction. A very good evening to all. And once again today, I would like to thank on behalf of Narayana Health, SOCHAM for creating this platform where we can connect to so many individuals from the comforts of their homes and offices. We would also like to thank the Dharamshila Narayana Super Specialty Hospital and their consultants for their vast experience and expertise for which they have come with us today to share. Dharamshila Narayana Super Specialty Hospital is a NABH accredited hospital and is providing services for cardiology, cardiovascular surgery, oncology, orthopedics, the bone marrow transplant services, kidney transplant services, neurosciences, and many others. Dharamshila Narayana Super Specialty Hospital has been in existence for last 25 years. Even in this lockdown situation, the Dharamshila Hospital has been functioning round the clock and has taken all the safe measures, preventive measures to ensure that every patient visit is safe. And they have also started a NH video consultation program. This is an effort to reduce the risk of contracting in coronavirus infection in this prevailing coronavirus pandemic. As it was stressed yesterday also that besides the common symptoms of malaise, fever, and the respiratory manifestations, the virus has also shown neurotropism. So it's imperative that we further know about the neurological signs and symptoms. And for that, we have with us our two eminent speakers, Dr. Ashish Srivastava and Dr. Amit Srivastava. I welcome them both. And today I have the honor first to invite Dr. Ashish Srivastava. Dr. Ashish Srivastava is the senior consultant and head of the Department of Neurosurgery at Dharamshila Narayana Super Specialty Hospital. He's done his MBBS, MS General Surgery and MCH Neurosurgery from prestigious institute AIMS New Delhi. He also has done his fellowship in neurosurgery from University Medical Center, USA, and worked as consultant neurosurgeon at Queen's Medical Center, Nottingham, UK. He's also acquired advanced skills in neurosurgery at Singapore and Germany, and trained and experienced in a wide spectrum of neurosurgical management with major interests in tumors, skull-based vascular neurosurgery, complex spinal surgeries, and in neuromodulation. He has won many awards and accolades in his lifetime. Overall, he has 26 years of neurosurgical experience. So I invite Dr. Ashish Srivastava to deliver his talk. He'll be letting us know how this coronavirus has impacted the neurosurgical practice. Dr. Ashish, please.
Good afternoon. Good afternoon, everybody. Thank you, Dr. Neha, for your very kind words. And thanks, Asucham, for this opportunity to interact with people on the impact of the current pandemic of coronavirus on the discipline of neurosurgery. I will start off with my presentation. And as you can see, the coronavirus has affected every aspect of life. And this has affected health services in all disciplines. Let me talk about neurosurgery today. Now, the impact of this pandemic of coronavirus has been on patients, neurosurgeons, and associated colleagues, on the neurosurgical procedures, hospital resources, and very importantly, not to ignore the financial aspects of treatment in neurosurgery. This impact has not only affected an individual city or one hospital, it has affected all over India, in fact, all over the world. And the impact has been similar. It has not spared the rich countries, it has not affected the poor countries more. It has been a very, very drastic impact in all spheres. Now, let's see how a patient interacts with a neurosurgeon for any kind of treatment. It boils down to points of interaction, which are three. Accidents and emergency department, we all know. I bang my head, get a head injury, and I go and attend the emergency for treatment. Other than that, the patients for neurosurgical treatment go to the outpatient department or the OPD, either before the operation or after the operation for follow-up. And of course, the longest interaction is during the admission in the hospital of the patient with the health team or the treating team. One of the benefits, of course, we are going to talk about how is it has impacted adversely, but one of the relative benefits of this pandemic has been due to the precautionary lockdown. The number of head injuries was reduced or has continued to be less than before. So let's take the first point of interaction, that is the outpatient department. And the traditional interaction has been in an outpatient department chamber where the patient sees the neurosurgeon, discusses the problems, is advised investigations, treatment, or a surgery. However, during the period of this pandemic, the need for distant communication, distant consultation has risen all the more. Digital platforms were there before, but not so commonly accepted or used. But now there has to be a very judicious balance between face-to-face interaction and digital interaction through distant communication. So this choice will depend on the clinical necessity, the urgency of the consultation, and suppose there is a communication which is to be given for major alteration in treatment, then a face-to-face consultation would probably be necessary and advantageous. However, sometimes a detailed neurological examination necessitates that the patient be seen by the doctor or the neurosurgeon physically, whereas routine reviews, follow-up visits after the surgery, or just to see that everything is going all right, they can very well be managed with preliminary evaluation, with just distant communication. Sometimes the distant communication can be done as a preliminary evaluation to decide whether a face-to-face interaction is needed at all, because the patient knows his symptoms. He doesn't know whether they are serious or they need the doctor's personal physical attendance or not. So we have to strike a balance. Now, suppose a patient it has been decided that he or she needs a surgery. So neurosurgical treatment will require preparation for the operation, the operation itself or the procedure, and the period of convalescence or the post-procedure period. So these are the three major areas where the patient will be interacting and the neurosurgeon has to look after him. So I would like to give a small background about this coronavirus, although nobody in this world so far, howsoever qualified or advanced in learning, has said the last word. But what we know more or less is that the virus incubates in about 4 to 6 days. So for safety's sake, let us take 4 days as the incubation period of this virus. So what we are following as a safe strategy is that we get the sample tested on the day one. Suppose for arbitrary sake, we take 25th of May this year. The report is usually available on 26th within 24 hours. Some centers do it early, some may take a little more time. So taking 4 days from 25th, the patient should be operated and is operated in our center within 4 days, that is the 29th of May, giving a period of about 72 hours in which to prepare for surgery, routine investigations, etc. So this is the time limit or time frame we have created so that the patient is operated within the incubation period if he has a virus. Because I'll come to the reasons why the test is sort of under the scrutiny. Taking that forward, the incubation period, as I said, was 4 to 6 days. However, the test is very, shall I say, is not standardized, if I may say that. Sometimes we are getting reports that the patient was negative, became positive later. So there is 3 situations where the patient can be there. The first test is negative and it remains negative on second testing. The first test was negative, but the patient becomes positive later on. And suppose the patient was positive and goes either way in the later period. So we take a safe route. We follow universal precaution in all cases because the test has its limitations. There's a false negative, false positive percentage, and the dilemma is there whether the test is actually positive or not. In fact, in the best of places, the COVID test at best has about 60% confidence, 60% confidence in the first 1 week. So you are better off following universal precautions in all cases of requiring neurosurgery treatment. Now, the foremost principle we follow in neurosurgery is SHIELD, safety. Safety, even without the pandemic, neurosurgery is one subject where we follow all steps to make everything safe, because the disease itself can be quite morbid or has a high mortality. So we have to make safe everything. So who do we make safe? The patient foremost, but the neurosurgeon, the anesthesiologist, the nurses, the technicians in the staff, the treating team, they also have to be made as safe as possible, because you cannot have a situation where one individual is safe and the other is not, or the second person is not sure about the status. So you have to worry about individual safety, because that's all leads to collective safety. Now, all surgeries produce what is known as aerosol. There are fine droplets of blood or water or bone material or something. All surgeries, in principle, that's a rule. Neurosurgery, we use a lot of high-speed drills on the cutting the bone, etc. And we use bipolar or electrical cautery for coagulating blood vessels. Now, these generate quite an amount of aerosols. The patient has to be given general anesthesia. So anesthetic induction directly is, you are working on the respiratory tract. So they also produce aerosols. And the operation theater is a very unique place. It defies all the requirements we are following in pandemic. You are there for long hours in a closed airspace. Now, closed airspace has been found to be the single most important factor in transmitting the infection from one to another. And proximity. I can't stand 2 meters away from the patient. Neither can my anesthetist be 2 meters away from the patient. So the proximity of the personnel, long hours within a closed confined space and the closed airspace, this is a setting in which the transmission can happen. So we have to make this, and the patient is lying unconscious. So you have to make everybody safe. Let us also see the plight of the treating team. Neurosurgery usually lasts for long hours. Average of 3 to 4 hours is minimum. It can go up to 6, 8, 10 hours depending on the procedure. And now with the coronavirus, it has impacted us that we have to take all precautions, as I said. So we wear precautionary personal protective equipment, the shield, the double masking, and the gown, which is very special, doesn't allow aerosols to enter. So you can imagine for 4 hours, if somebody is working in a closed space wearing 3-layered protection, he or she can become what is seen in the toaster. Apart from this, you can imagine from a routine neurosurgery operation, here we are testing for corona, providing all sorts of protective equipment to the personnel, to everybody in the hospital. The hospital is geared to look after the patient in a different manner. So the cost of care has spiraled quite high. And the burden of that is borne not only by the poor individual, but the society in general. So when we have to take decisions about neurosurgical operations, you are in a dilemma. The dilemma of aggressive treatment, long surgeries, difficult surgeries, dangerous surgeries, and it is balanced by the extreme precautions to make everybody safe, to make the surgery safe, to make the patient safe, and the healthcare team safe. So the judgment has to be very, very finely balanced. However, you can imagine that in a situation like corona pandemic, there are more than just one player on the side of the seesaw. There can be multiple players on each side, and the decision becomes even more difficult. So long as human history has been written, there has been an eternal tug of war. The tug of war between what you have as resources and what you require for surviving or living or for anything. So it's the eternal tug of war between resources and requirements. And this has been brought to note much more vividly during the current pandemic. Another thing, the eternal game. The moment we are born and till the time we abandon this world, we are juggling in life. We are juggling in home life. We are juggling with our work. We are juggling with family, the friends, and juggling money for different needs. However, we tend to manage somehow or the other. But when it comes to juggling about major decisions in neurosurgery, it can be very precarious. Now imagine this traffic diversion. This is what pandemic corona has done to every nation, every society all over the world. Since the number is large, a large amount of resources have to be diverted to managing the pandemic, managing the sick patients, managing the services, and the most important procedure followed for preventing infection was social distancing, lockdown, clamping interaction. That has had its own effect on diversion of resources. So once you have a diversion of resources, it affects both manpower, the infrastructure, and the finances. In the infrastructure, we are very acutely aware of the need for more ICU beds, more ventilators, more hospital space, more spaces for quarantine. So the diversion of these resources has affected neurosurgery and its practice and the treatment of people requiring neurosurgical treatment. Let's see. One of the sad effects of this diversion has been that you have to triage. Triaging means providing resources according to need. Now, resources are few, and the corona has diverted most of the resources to management of the pandemic. So when it comes to a neurosurgical patient, you have to very acutely be aware that your resources are now limited. Your ventilator beds in the ICU have been diverted for sick patients of the coronavirus. So if you are operating on neurosurgical patient, you may not have the ICU bed, or the ventilator may be in short supply. Once a situation like this is there, you start choosing which patient should be operated urgently or can be delayed. Such a triaging can have an effect both personal as well as on the society. Let us see, in the personal level, an individual, there can be strong emotions. Some of them positive. Yes, they have empathy for the patient. They have faith that yes, the doctor will look after, or the system will look after. However, there can be very strong negative reactions. We all are aware how doctors have been treated by a certain section of people when their objectives were not met by the healthcare system. Anger, sadness, fear of the disease, as well as in some families a feeling of guilt that we are not able to garner the kind of treatment that the patient deserves. Similarly, in the society, a lot of big issues crop up once you start triaging. We all know about Italy, where at one stage the healthcare system was in dire states and they had to choose whom to treat. Now, they decided not to treat people above the age of 80, if I'm correct. Now, that can lead to a lot of society issues. Are we playing God? Are we trying to decide that who will live and who will not? And the media plays its role. Information has to be dissipated, and education has to be provided to the people that it's a situation. Pandemic has created this situation. Not everybody can undergo a back pain surgery. Now, all procedures in surgery can be classified very simply into three categories. Procedures which are emergent procedures, which have to be done without any delay. Then there are procedures which are essential, unavoidable, but do not have to be done. We don't have to do them right away at this very moment or within the next 2 hours or 4 hours. They can be done planned. And then there are procedures which are indicated but can be easily delayed to a later date. Two main types of surgeries are done by neurosurgeons. One is the brain surgery or the intracranial surgery. By and large, intracranial surgery will be essential, unavoidable, and sometimes emergent, as in head injury. But please remember that, as I mentioned in the slides, head injury incidence has come down during this pandemic because of the lockdowns. The other part is the spinal surgery. Usually, spinal surgeries can be deferred unless there is a rapidly evolving neurological deficit or there is impending severe neurological deficit. To give an example, I operated on a patient during this pandemic period, a 47-year-old male who had prostatic malignancy, which had collapsed or caused to collapse the cervical vertebra, the fifth cervical vertebra. His power and functions were intact. If I did not stabilize the neck by taking out that bone and fixing it with implants, at any moment he could have developed quadriplegia. So such spinal surgery is mandatory, and that was done. So when you are in a situation where resources are less, they have been diverted for something very important and essential, then you have to start thinking of alternative methods of managing the situation. As I said, some surgeries can be deferred or some treatments can be deferred. So you consider alternative therapies, adjuvant therapies for such problems. You have to prognosticate very carefully and evaluate the logistics of a particular center. You don't have unlimited resources to treat everybody. So suppose there's a patient who has to be operated, but he will require a long surgery. It's a high-risk patient and is going to have a turbulent convalescence with long ICU stay and maybe requiring a prolonged ventilatory support. Say, for example, a patient of brain cancer or glioblastoma, as we call it, in an aged patient. The survival in these patients is less than a year, and of that 1 year, maybe 2 to 4 weeks will be spent getting the surgery and then coming out of the surgery and recovering. Do we counsel the patient? The Western countries are doing that. They have a big organized sector of health, and they counsel the patients, talk to the family. We tell them the pros and cons of operating, not operating, and some of them can accept that the surgery be deferred and alternative method be done so that the patient does not suffer without undergoing a major surgery. But then, as I said, are we playing God in this situation? Nobody likes to play God. No doctor likes to play God. After a neurosurgical procedure, the usual requirements are an ICU for at least a day or two, sometimes longer. Most of the patients with brain surgery will require ventilatory support transiently or maybe on a longer basis. Excuse me. Now, ICU is also a closed air space with a lot of patients and healthcare workers and nurses and doctors coming and going. A large number of patients undergoing neurosurgical procedures have comorbidities like high blood pressure, diabetes, hypothyroidism, and maybe of middle or advanced age. A large number are also on steroids, which cause immunocompromise. And even if they are not on ventilator or completely unconscious, they may be in altered sensorium partially, and some of the reflexes like coughing may be compromised. So these are ideal situations for them to become sick, and God forbid if they have corona, then the prognosis becomes dismal. Let us see how we tackle this post-operative period. The patient's test was done on day 1, operated within 96 hours, and in the post-operative period, if the patient recovers within the 4 days, you do nothing. The patient goes home if he's all right, he or she's all right, and has recovered. However, if the post-operative period lasts more than 8 days, then you will have to repeat the test. And again, the same dilemma which I showed in the previous slides: negative remains negative, or negative becomes positive, and then the whole system has to be changed and tailored according to a positive corona patient rather than just a negative elective surgery. Now, I would like to draw the attention of everybody, the people, the doctors, the hospitals, the healthcare managers, that while we are having a very grave situation with the corona pandemic, other diseases have not disappeared. A patient with diabetes will have problems. A patient may develop other disease, and this should not be neglected in the frenzy of treating only the corona pandemic. So other diseases cannot be neglected, and they will also demand the scarce resources, but they will definitely need the treatment which they need. Apart from this, the last word, as I said, about corona has not been said, whether it pertains to its pathophysiology, how it causes the problems. First, it was believed to be a pneumonia. Now it is believed to be a situation of some thrombotic abnormality. And so, every day we come across new information. The last word has not been said. First, it was thought only respiratory problems, but now we know as neurosurgeons, as neurologists, that neurological manifestations are well known with corona now, and people have suffered from that. So essentially, the coronavirus has introduced an element of unknown. Nobody knows. The best experts cannot say with confidence, or with 100% confidence, or even 90% confidence, what it will do. So this uncertainty reflects an element of unknown for the patient, for the medical professionals, and for healthcare in all its aspects, not just the treatment part. So according to one of the studies, there was a 20.6% increase in the risk of complications and morbidity, which may translate into increased mortality after any surgical procedure, especially neurosurgery, and even in COVID negative patients. So, COVID test has its uses. You can form guidelines, but it's not the ultimate protection against coronavirus. So my message would be: stay safe, stay healthy, do not require neurosurgery, but if it is required, it needs to be done. Thank you so much for your attention.
Dr. Neha, please unmute yourself. You are not audible.
Sorry. Thank you, Dr. Ashish, for such a beautiful, concise depiction of the changes in the neurosurgical practices and the dilemma which is existing in this COVID-19 era. So we'll have the discussion session afterwards, or the question answers session after the second talk is over. So now I would like to invite Dr. Amit Srivastava for his talk on neurological complication in COVID-19 era, and he is Dr. Amit is the senior consultant neurology at Dharamshila Narayana Super Specialty Hospital, Delhi. He's done his MD in medicine from MGH Medical College, Indore, MP, and done his DM in neurology from the prestigious Christian Medical College, Vellore. He has over 17 years of clinical experience in neurology and has worked with many reputed hospitals in Delhi and NCR. He has also established the acute stroke management protocols in 2 of the previous hospitals. He also worked as an assistant professor of neurology for 2 years at CMC Vellore, and he has interest and vast experience in treating headaches, Parkinson's disease, and other movement disorders, epilepsy, botulinum toxin, and treatment for spasticity and other indications, and other disorders like multiple sclerosis. He has won the first prize for his paper on the clinical profile of ADM, and he has delivered many lectures on various medical forums of national repute. So now I invite Dr. Amit for his talk. Dr. Amit, please.
Hi. Am I audible? Hello?
Yes, Dr. Amit, you are audible.
Okay. So, first of all, thank you, Dr. Neha, for your kind introduction. And thank you, SOCHAM, for giving me this, great opportunity to speak on a topic where I am actually, I am following. The good thing is that I am following, 3 eloquent speakers who have already, given a very good backdrop of the problems faced by, the doctors and the patients in the field of neurology, or say neurosurgery. Dr. Ashish particularly was, very, eloquent, and he was quite cogently has put all the problems faced by the patients as well as the doctors. The problem is, most of the time the side of the doctors always get suppressed in this. So we are warriors, corona warriors, so our story goes silent. So anyway, so I would just like to my topic would be more like a generalist topic, wherein I would like to touch about most of the complications in what are faced by the people during this COVID time. So just let me start my presentation. So is the presentation visible?
Yes, this is visible.
Yeah, it is visible. Please go
It is
ahead.
visible.
Okay. So without much ado, I'll just start my presentation. Good afternoon, everybody. So this is a pandemic. It's a huge crisis of unprecedented proportions. The last pandemic that the human race faced was about a century back. So this time, most of the time it has been in the recent times, the pandemics and these diseases have been unleashed by the viruses. So again, this time it is again a virus, which is called the severe acute respiratory syndrome coronavirus, COVID-19 in short, and it's really wreaked havoc worldwide. It's been having an unprecedented impact on the public health and the society. The WHO declared it as a pandemic in the month of March 2020, and since then it's sort of going up and up. In many countries they have peaked, they're sort of plateauing and now coming down. But in India, in our scenario, it seems that we are yet to achieve the peak. The lockdowns did help, but now the unlocking is actually seeing skyrocketing of the patients. We have almost 1.7 lakhs, so probably more because this is yesterday's data, and we have climbed up to the being the 9th country in the highest order of having the cases. But the silver lining is that most of the cases, more than 80-85% of cases, are asymptomatic. So that's a very good thing. And in specifically pertaining to India, the case the mortality rate in India is quite less. The case fatality rate is around 1.3 to 1.5. 0.3 to 0.5, whereas the world average is around 4.5. So just to put it in perspective, UK has a case fatality rate of almost 55 and US as 29. So I think we are faring quite well, despite the fact that there is a lot of chaos, confusion, and what to do, what not to do. We are just sort of hurtling down the cascade of cases, but then the deaths are less, so that's a good consolation. So now, so what are the directly? So first, I'll divide my talk into the directly related neuro complications of COVID. So there was a study from China, Wuhan, wherein they said that almost 36% of all patients did manifest with neuro symptoms. The most commonest symptom was dizziness. So I have seen a lot of patients of late who's come with dizziness and they have no other symptoms. Though obviously just with dizziness there's no point testing for COVID, but it was noticed that a lot of patients were coming with dizziness. Then a lot of patients who they have said is a complication of COVID is headaches. Then you have these muscle injury which leads to generalized muscle aches. When you test, your CPKs will be a bit on the higher-ish side. A very peculiar symptom that has been even noted by the CDC is that there is a loss of smell, anosmia, and there is a loss of taste. What we call as ageusia in almost 5 to 6% of cases. In fact, these cases are mostly seen in patients who usually don't have or they are very early signs of or symptoms of COVID-19. So, in fact, this because headache, dizziness, and all are very non-specific symptoms. They can be there in most of the viral infections, but specifically this loss of smell and taste has been sort of touted to be one of the early symptoms which can actually be used as a screen test in OPDs, wherein if you can ask these questions, and if you feel that the patient is telling that they have these symptoms, and even if they don't have any of the symptoms, it's worthwhile going and getting the COVID tested. Then coming to the more sinister syndromes that we encounter with COVID, we have these strokes, which is the commonest type of complication or most talked about complication in COVID-19. My colleague Dr. Sahil, has given a very good insight into the scenario of ischemic strokes vis-a-vis COVID-19 yesterday. I hope you must have all gone through his session. I'll be just sort of going through it again in a very generalist way. Then we have this Guillain-Barre syndrome. The Guillain-Barre syndrome is actually a immune-mediated syndrome wherein you get all your nerves, the roots of the nerves, they get an immune reaction, and so your nerves become weak. So how you present is you have a generalized weakness which usually starts from the legs, from one leg, then it goes to the other leg, then it goes to the hands, it can go to your face, it can actually affect your breathing muscles, and you may actually land up on a ventilator. So they are mostly having motor symptoms. They usually don't have any sensory symptoms, and your bladder, bowel, and other higher mental functions are preserved in this syndrome. So this is one. So if so broadly, the problems or complications that we have seen because of COVID, even if you see in the other system, respiratory system, even in the kidney or heart. So what we're seeing is there are two predominant things. The one is the triggering of the thrombotic cascade. You tend to form a lot of clots. So they're saying that clots in the lungs, there are clots in the kidney, they're having problems in the liver. And then the other important aspect is the triggering of the immune system. So in fact, the point from where the patient starts going down in most of the cases that have been described is after you get what we call as a immune storm. So even in the complications of neurology, if you see, so ischemic strokes predominantly are because of the increased clotting function, which is triggered by the COVID-19. Also, strokes are happening because of the triggering of the inflammation of the inner layer of the vessels, which is called as the endothelial layers. So they get inflamed. So together with the inflammation of the inner layer of the vessels and with a higher tendency to clot, so you tend to form these clots all over. So in the brain, when they form clots, you tend to have what we call as ischemic strokes. Guillain-Barre syndrome is actually an immune-mediated reaction. Then we have these patients who we have seen are having a lot of irritability. They are sort of having confusion. They're delirious. They're having headaches. What we call as an encephalopathy. So these are also seen in a lot of patients, both in early stages as well as in the late stages of these COVID patients. Then a very interesting thing, which I have seen more as an anecdotal cases in when I was just trying to look for the literature. And there's a lot of the rise of this commonly called what we call as the seventh nerve palsy, what we call as the Bell's palsy. In Hindi, इसको हम कहते हैं चेहरे की fallish, चेहरे का एक तरफ it gets paralyzed, so wherein you are not able to close your one eye, and your face sort of droops on one side. So this is because of the paralysis of the seventh cranial nerve. So a lot of there has been a surge of these Bell's palsies, in the this during this COVID times. I personally, must have seen almost 10 to 15 cases in the last 2 months, which is actually quite huge because usually this Bell's palsy happens in the month of winters. So having it during the summers is quite odd. In fact, 2 patients I encountered were of the age of 10 and one child was of 12 years of age, which is again very unusual for Bell's palsy to hit the children. At the same time, none of these patients had any telltale evidence of any viral infection. They didn't have any fever, no cough, no respiratory problems, lethargy. So they just purely presented with Bell's palsy. Obviously, I didn't go for the test because it's not recommended as well. But that was something which I noted. I tried to look in the literature, but I didn't find any study on this. So now coming to the most talked about complication of coronavirus, which obviously Dr. Sahil has covered, but I'll just be going through it rapidly and just touching the important aspects of it. So strokes in COVID patients have actually been quite a challenging thing for the neurologists. So what we have seen is that so you can divide the strokes into 2 sections. One is strokes in COVID patients, and then strokes in non-COVID patients. So just first talking about strokes in these COVID patients. So what we've seen is that, as I described earlier, that because of the rise in the tendency of clotting and the inflammation of the vessels, we have seen patients who earlier didn't have any significant risk factors for stroke, the traditional risk factors, which are age, diabetes, hypertension, smoking, high homocysteine levels and high cholesterols. So most of these patients didn't have this as comorbidities. They presented with strokes. Many of them were actually younger than 50 years of age, and there were a lot of patients were having large vessel strokes. So large vessel strokes means like the the internal carotid artery, the middle cerebral artery, and many of them actually presented as a first time. I mean, the strokes were the first symptoms, so they presented with strokes to the casualty, and they didn't have any other symptoms like cough, fever and all. So that was one section of people. Then you also had another section of people who actually had COVID. They were diagnosed cases of COVID, and then when they were while during the course of the treatment they developed strokes. NAGM has done a study, the Lancet has put their own study. So both have sort of done their studies in different cohort of patients. One is predominantly had more of asymptomatic patients presenting like stroke as the first, and they were more in the younger category and all. And then the other cohort is of more these patients who were actually going treatment. They were already sick and then they developed strokes. So the other mechanism of strokes in these patients, what was found was that of thrombotic, cardioembolic, or actually it is suspected cardioembolic, but when they did the echo and all, nothing was found. So basically you had these shower of emboli. So you had a brain where you had small clots, and even the presentation was not that of a very typical stroke, as in they didn't present with, say, a right-sided weakness or a left-sided weakness or sudden acute weakness or any difficulty. They actually presented with what we call as an encephalopathic picture of stroke, wherein patient presents with more like delirium, confusion, and when you do an MRI, you find you have got disseminated small clots all over the brain. So this was also noticed in these COVID patients. And when, but most of them, when they were investigated for risk factors or the typical things that we do for finding out whether there is a stroke risk factors, most of them didn't have anything. So they were even labeled as cryptogenic in nature, as in where we couldn't find any reason. So other important thing was comparative to the prognosis of general stroke patients. The stroke patients in COVID were actually having a poorer prognosis. So most of them presented by 10 days of their infection. So that was one thing. When the blood tests were done, labs were then done. There, the D dimers were found to be high. They had a DIC kind of picture. The platelets were low. So in fact, due to this, presentation of patients having, strokes as a first symptom, wherein other symptoms had not materialized by that time, or a patient, coming with strokes, having along with that cough. So in fact, the American Heart Association and the American Stroke Association actually tweak the, the criterion and, the triage, how to triage stroke patients. So, initially, the traditional thing is, if a patient has come with stroke, then we usually only concentrate on, managing this, looking for stroke, we do a CT scan. Now what they did is they added a CT, what we call as a 2 CT formula, wherein they said if a patient has come with stroke, might as well get a CT scan of the brain as well as the chest, because you may find a CT or at least an X-ray of the chest, because you may find early signs of COVID respiratory involvement when you do a CT scan of the chest. So that was something which has sort of become a recommendation now in most of the ERs. So now the other problem is with the strokes in non-COVID patients. So in general, there were a lot of news of most of the stroke centers observing that the patients, the patient load has become quite less. They said in most of the stroke centers, they said that patients, the loads had reduced by almost 30 to 40% patients coming with strokes. So when they then try to find out what was the reason, obviously other things were kept into consideration, that maybe the lockdown has sort of reduced the stress level of the patients, and people are not having the hassles of driving and stress and blah blah whatever. Maybe that is one reason. But when they actually tried to do a study and find out what was the reason behind it, they realized that actually a lot of it was because of the fear of patients. They don't want to venture out during this bad COVID times. The fact is that more than doctors, actually the patients nowadays are scared to go to the hospital, thinking that they may catch COVID. So it was, the studies show that the most important thing, the thing sacrosanct in the treatment for acute strokes is that the patient should try and reach the hospital within what we call as the golden period, that is 4.5 hours. Now when they did study, most centers found that what we call as the door to needle time. Door means when the patient was so one was the door, one was symptom to door time, right? Symptom to door time means the patient, when the patient was found to have diagnosed as probably some symptoms of stroke, and when the patient was brought to the hospital. So that so dramatically was lengthened, and many of the patients never turned up. Now the other thing is, when the patient has come to your triage, from there the door to needle time is all the neurologists or stroke neurologists try to endeavor is that it should be less than 1 hour. Means we should try to do all the investigations, as in to find out whether this patient requires the treatment, which is either an endovascular in thrombectomy, means taking out the clot, or giving the IV clot buster medicine. So that decision time to starting it, we should try and squeeze it between an hour. So this door to needle time actually had lost its sanctity because of multiple reasons. The reasons being the ER, which was earlier made very stroke sensitive, people were stroke conscious. So because of the COVID times, the attentions have been diverted. People, the ER staff, even the ER doctors, they're more into taking care of COVID patients, and trying to be alarmed about symptoms, asking more symptoms about COVID. Then the the time of examination as patient, because the fear of infection, catching infection, the doctors, the ER staff, they'll have to be in their PPEs. Then they have to there is a lot of things, the protocols set in because of the COVID times, wherein you have to first do the fever thing, blah blah and all that. So that really increased the door to needle time. Plus, most of the time, the staff, the staff, as in the neurologist, or say the endovascular uh, vascular surgeon, they were also not available because of the because all the attention has been shifted for treating COVID patients. Even they're traveling, even if they're sitting at home, and when they were called, they took a long time because because of the traffic snarls, the all that lockdown regulations. So there were problems and confusion galore. So patients never turned up to the hospital because of the fear of catching corona. Then they had the fear how to reach the hospital. In between, the police walas will catch you. They'll ask for a pass. If you don't have a pass, they will hit you. And then we had cases all on social media, where you saw how some people were treated. So the other reason was, during this the social distancing time, what happened is most of the elderly people, they were sort of isolated in the whole scheme of things. So the people, elderly people, were already staying alone. They got totally isolated. They were not in connect with their relatives. They were not in connect with their neighbors. And some this also happened that people who are actually having elderly people in their homes, they also sort of socially distance themselves in whatever possible way. They either shifted into a separate room, wherein they were sort of very less observed. So all these things led to a delay of identifying these stroke patients. So uh, uh, so as I said, there are almost 20 to 36% of cases of non-COVID patients who actually had stroke could not actually, be treated. So that is a very sad part of it. And I think Dr. Ashish had very well mentioned about it, that, in our frenzy and, panic to treat these stroke patients, these COVID patients, and, the whole healthcare system geared to, only, focus on the corona infection and all that. So the non-COVID patients, non-COVID complications and diseases really got totally neglected. And I think we are not seeing the end of it. As the numbers are going up in India, and with our very restricted and limited healthcare resources, it's all going to be eaten up by the COVID patients, and we are really going to have a tough time treating non-COVID patients. So this is again, I think Sahil must have gone through it. It's a busy slide, so I'll use a simpler one. This is a flow chart for how the various associations have sort of made a flow chart to advisory as to how to treat stroke patients. So this is a simple one. So what we basically do is that so there are either a patient who has come to your ER who you think is having come with an acute stroke. So you have to quickly triage it. whether the patient is a known case of, whether the patient is COVID, patient is a suspected COVID, or patient is a, not a COVID suspect. So COVID positive patients, no problem, he is positive. So then, you do the, the protocol to try and find out whether this patient is a candidate for thrombolysis, thrombectomy, or he is out of the window period. We do that. And then if it is a large vessel occlusion and within the window period, so you have to wheel into the, operation theater, the vascular lab. There, the procedure has to be done, preferably under general anesthesia. And then, if the patient is treated under general anesthesia, shift him to the special ICU. Otherwise, if you have been able to do it under local, you can shift the patient to a dedicated COVID-19 medical ward. So basically, the COVID-19 patients go to a segregated, isolated space made for COVID patients. Then you have these COVID suspect patients. So who are these COVID suspected patients? Probably, patients who are, coming from the hotspot area, along with the, stroke, they also have, cough, fever, and all that stuff, right? So for these patients, we again don't delay the process of, treatment. We have to quickly take a nasopharyngeal swab, send it for COVID testing, and at the same time, you have to start our protocol for, what we call as acute stroke treatment protocol. But obviously, with this patient, you have to be very careful. You just ensure that all your staff dealing with the patient has to be in proper PPEs. Again, the flow goes same way. If you find a large vessel stroke, patient goes into the endovascular therapy arm. If no, then goes to the routine, thing. And then here also, till we get the COVID report, the patient is supposed to be segregated in a separate, ward or ICU. The COVID report comes in 24 hours. If it's positive, the patient stays there or goes to whatever is the protocol, to a area dedicated for COVID. If the test is negative, patient is shifted to the routine medical ICU and the stroke is treated as per protocol. Then the third is, there is a COVID patient who is not a suspected COVID patient, right? So he's not from a hotspot. Again, this is a very tricky thing because, as I told you earlier also, that, COVID patients are coming with first symptoms with strokes, right? They may not have anything. They may even not be from the hotspot area. So this again is a very, tricky area. You need to be, so as if now, the protocol is any patient coming to you, it is wiser to think that this patient is COVID positive until proved otherwise. When I say that, I do not mean to say that, you need to, treat the patient, delay the treatment or anything. What I only meant is that you need to take the necessary precautions. That's the most important thing. And in these cases, patients also, I would suggest that we should, along with the, CT or MR of the brain, we should also do a CT chest, because patients, absolutely asymptomatic patients, may have certain changes, early changes of COVID in the chest. So we can do that and then, proceed further. So now I come to a probably the most, broad, complication of, neurological complications in the society, which this COVID has actually unleashed. They are more to do with, neuropsychiatric issues. My psychiatric friends, my psychologist friends, obviously they are dealing with a lot of patients in this COVID time, but we as neurologists also see a lot of, neuropsychiatric patients, and, what we have encountered is there is a huge upsurge of, patients coming with anxiety, depression, stress disorder. Earlier the panic attacks have gone up, the post-traumatic stress disorder episodes have gone up. There have been a lot of suicides and suicide attempts. Recently there was a, a TV personality, Preksha Mehta in Indore. She committed suicide. So it's not that, the suicide is only happening in the lower strata. In fact, surprisingly, though the migrant labor population, which is actually suffering a lot, but the suicide rates, if you see, is very, very, very less. They're dying out of due to some other calamities for sure, but probably they are more mentally tougher than the other class of society. Then also we are having a lot of marital discords, which people have given a very funny name called as COVID divorces. There have been instances wherein so it's like there is a couple which already has got some lingering problems. There are some marital discord, but because of they've been busy with their job, and things have been lingering on. But this what has happened is during this lockdown they're sort of forced to stay together and fight more often, it seems. So so there was a great rise in the number of COVID divorces. This was not more so in a problem more in India, but in Western countries especially. I was reading in the newspapers that in Japan it was a huge problem. So what they did is that the government offered separate isolation facilities for husband and wives, so that they could live separate and not end up with divorces. uh, then you had this issue of alcohol. So that was I'll show you a slide also which the WHO has shown. So people who are sort of used to taking alcohol, suddenly due to lockdown, the alcohol was it became a prohibited thing. So people who were sort of addicted to alcohol, they had problems. People who drink as a social thing also, they also had problems. So this also led to a lot of, so many of my psychiatrist friends did tell me that during this lockdown period we saw the maximum number of alcohol related neurological psychiatric problems. So the WHO actually they have been giving out advisories like this, wherein they said that how to deal with stress. So what they said is try to be in connect with your near and dear ones on phone. uh, so if you're at home, do healthy practices, eat properly, have a good sleep, exercise at home, in whatever possible way, do some walking and all that stuff. Don't smoke, don't take alcohol, don't take drugs, don't get sort of hooked on to all those things. So these were the things. Then the biggest thing was there was a lot of information coming in from all sides, so they had advised that don't go after those advices blindly. Try and select and sieve out which is relevant information and which is fake news. Then they said that limit your you know TV, watching TV and all that, and involve yourself in more creative job. Sort of try and find out what is your creative side, and try and do things in that, or to sort of engage yourself in a more productive manner. So as I said, along with the pandemic came the infodemic. So I don't need to elaborate on that. The moment I would say this, everybody must have really understood what I'm alluding to. So the infodemic, there were WhatsApp messages, people it was a deluge of information, people giving their expert comments, and sorry to say, even these webinars sort of contributed to it. There were of every place, everybody was doing a webinar on COVID, how to manage COVID, what is COVID, uh, how are we going to end up with COVID, what is the economic losses we are going to suffer, has the world come to an end, and so on and so forth. So it was a huge problem with the this infodemic was more dangerous than the pandemic, many people would say. So the idiot box, the TV, obviously the news anchors going on and on with incessant news. Then your social media, everything was you know sort of bombarding you with COVID related news. And you had these COVID watches, timelines where every patient, it was ticking, like every time a COVID patient came positive, it used to show it on the wall. Every death was being shown, so it was actually it was enough to cause a lot of stress on the people. Then obviously a lot of jobs were lost, livelihood suffered. There were slashed salaries. many people had, future plans, they had taken up loans, they had put up things, everything, sort of went into a jeopardy. In fact, what people are saying is that, we are actually as if now facing the, the medical as in, directly the medical part of, the COVID pandemic, the financial part of it, and probably the, the mental part of it, the mental diseases will, actually be seen, much more after the pandemic goes off. So that's a really alarming thing, and the government has to do a lot about it. The civil society as such, the doctors, the psychiatrists, they all need to do a lot of things about it. So then there was a problem with non-availability of drugs because of the disruption of the supply chain. The essential drugs were not available, especially these psychiatric medicines and neurology-related medicines. Anti-epileptic medication. These medicines are not given directly. They're not available over the counter. Then the doctors were not available. The most of the chemist shops were closed. So all the patients had real big problem, and especially all these patients who are on psychiatric medications, they had to, sort of, they there were a lot of default on medications, and they went into big, they were, went into depression. Patients who were actually doing well went into depression. So these issues came a lot. They were not able to meet their doctor because, of the lockdowns and the hospitals not functioning fully, a lot of restrictions there. So again, this is an advisory, how to maintain your mental health during the, COVID times. It's almost the same thing which I told you, earlier. The suicide rates had went up remarkably, both in the Western society as well as, a lot of, due to financial reasons, due to stress. The celebrity that I talked of, she was a TV celebrity. She was in between some project when, the lockdown came, and then, she went into a financial crisis, and then, she had a lot, lot of depression and all that, and then she finally committed suicide. So this was an aspect which was a very, very bad aspect of this COVID times. Then you had these, work from home and, work at home problem. So it's not that people who are working from home had no, they were free. They had to, work, do the other chores as well. The maids were not allowed during this time. The other helps were not allowed. So, you had to do all of the work on your own, as well as also, do your official work. So all these things, then the biggest problem with parents were these, this constant bombardment of these online classes by the schools. So there was a lot of stress which happened to, people who were, though they were, sort of living, peacefully in their houses, but actually they were having a lot of problems. So then there were the strict lockdown and restriction rules. There was a clamp down on regular morning walks or evening walks of people. These morning walks, evening walks are actually, they work, as a neurologist, and even psychiatrists will, will vouch for what I'm saying is, these morning walks, they really work as, very, good stress busters. So because of the lockdowns and strict lockdowns, people were not able to do their walks. They again, had a lot of, stress, tension because of that. Even children had, psychiatric problems. They were, behavioral issues. Sitting inside the house, they were having problem. They also, sitting with their parents, were, looking at this COVID, things, and the panic created and alarm created. They had a fear for, they started having morbid fear for death. There were children, there were parents who are saying that, the children started asking that, are we going to die? All these kind of, very weird questions. So during this time, obviously there were a lot of self-help groups, the psychiatrists, the social, media self-help groups, who had actually, reached out to these patients and those elderly people who are living in isolation. They gave out their, numbers. They even put out these, helpline numbers. They talked out to their relatives and all that stuff. So I mean, these all things happened during this uh, COVID times, just to ensure that the mental health was also protected. Alcohol, as I said, this is the advisory given by the World Health Organization vis-a-vis the alcohol thing. To be very frank, this alcohol prohibition was not, usually not seen in the western part of the world. So there, it was alcohol is part of, essential services, if I can say that. So, but in India, they had, put a strict prohibition on alcohol. But having said that, this was like, pushing the problem under the carpet. It is not that the Westerners they only take alcohol and Indians are, saints who don't take alcohol. So, everybody had a huge problem, so they had given an advisory that, preferably don't take alcohol, abstain from alcohol. If you are having, withdrawal symptoms, reach out to others, talk to other people, don't get to the urge of, taking alcohol. Don't go and start smoking with alcohol. Don't drink in front of your children. Never mix alcohol with, other medications. So, don't use stress and emotion as a, as a reason for starting alcohol, and make sure that the children are, not more. In fact, interestingly, there are a lot of news where, people had started, guzzling sanitizers, because sanitizers have 70% alcohol. So there in between, there were a lot of reports of people, drinking bottles and bottles of, sanitizers, and, landing up in trouble. So this was another aspect of it. So again, this led to a lot of confusion, stress. There were 2 or 3 suicides reported because of, people who are dependent on alcohol. They were not getting it, so they committed suicide. So now the indirect things of, neurological complications which we saw in neurological patient was probably because of the, lockdown effect. So there was a huge rise of in patients complaining of headaches. So these patients were both who were previously having headaches already, the cohort of patients who were, like already taking treatment for headache, say migraines, tension type headaches. And then there were a new set of patients who developed headaches because of the, myriad reasons that I've already explained, because of the stress of, the lockdown, stress of, not working, stress of losing jobs, blah, blah, whatever. So there was a huge rise of, patients with headaches. Thankfully, most of them were, non-sinister headaches. So when I say non-sinister, means they were vascular headaches, which is like tension type headaches and migraines, which, they may, have bad symptoms, but they are not sinister, as in, they're not malignant. So there was a huge number of patients who came up with headaches. Then, there were these quarantine blues again, which led to anxiety and stress. The obviously because of the disaster, act of the 1897 that was, suddenly invoked, obviously because of, the right reasons. So, but the downside of it was that a lot of freedom of individuals were curtailed during this time. So, people were bashed up, people were, slapped with FIRs, blah, blah, whatever. So all these things created a lot of problems, neurological problems, mostly having, led to, stress, anxiety, tension. Then a lot of patients who are of degenerative disorders like Parkinson's disease. So, there were a set of patients who were already on Parkinson's disease. Parkinson's disease is a disease which is very well controlled when the patients are on medications. So one part of it was, because of the, supply chain getting disrupted, many patients couldn't get their medications. Other aspect of Parkinson's disease is it is known to, get, off the hook, if there is in moments of stress, anxiety. Then morning walk, physical exercises are very essential part of keeping the Parkinson's, patients in good shape. So all these things got affected. So we had a huge upsurge of these, patients of already diagnosed cases of Parkinson's who actually, went down the hill during this, they have gone down during this pandemic period. Then there were these degenerative brain disorders like dementia and all. Again, same thing. medications, they could not get properly. Then again, stress, anxiety, locked inside a house, all these things affect a lot on the brains of these people. So many of them got into a lot of depression. Many of them started having hallucinations. There was a lot of, I used to get frantic calls from caregivers, which you call as caregiver burnout. So they were locked in the house with, say, a father or a mother who is having dementia, who was behaving weirdly. They couldn't go out, they couldn't get medications, they couldn't take them out to to the park, or they can even take them out for consultation. So all these things came up during this time, which was something which as a neurologist I did notice. And there was a lot of patients came to us with or complained to us about backaches and neck pains, again probably because of bad posture, sitting at home, not doing exercises. And obviously because many of the people who are not used to doing household work, especially the men folk, they were forced to work at home. So jhadu, pocha, bartan dhona, and whatever. And then all these techies who are given this work from home assignments, they were sitting 8 9 hours continuously on the computers at home. So they all landed up with backaches, neck pains, and a lot of these problems. So now I would also like to talk about the neurological issues that were faced by the COVID warriors. When I say COVID warriors, obviously all the frontline workers, which involved the doctors, the nurses, the ward boys, the police walas who were standing outside maintaining the law and order, the gatekeepers, the people who are supplying, part of the supply chain, the nurses, all these people were frontline COVID warriors. So though I am more focusing on my community, which is the doctors. So because obviously it goes without mention that the biggest burden was on them. So they had a lot of mental stress. They had caregiver burnout, which actually is a term we use for attendants of patients. But here what had happened is that because of the COVID being so highly infectious and most of the patients being quarantined and isolated, so by default it was the doctors who were not only treating the patient, but they were actually the caregivers, because relatives were not allowed nearby to the patients. And otherwise also we saw instances where the patients relatives would just scoot off once they came to know that the relatives are having, a father or mother is having a COVID. So the doctors had a lot of mental stress. Then they were seeing deaths happening. They were what they are actually still seeing deaths happening in front of them, people suffering, going on ventilators, breathless people. Then they were putting on these physical, they had to put on these hazmat suits, which is not a Dr. Ashish has already mentioned that putting on these treacherous, impervious hazmat suits is like actually like a torture. And then there was an advisory that you're not supposed to put on your AC systems because the vents may sort of transmit the COVID. So they had this situation where they had to put on these hazmat suits for 8 to 10 hours. Most of them were in non-AC ICUs. They were all in closed spaces, and again they had to hold the call of nature for 6 8 hours. Can you imagine that? So it was not only a mental drain out, it was a total physical drain out for all these doctors, and they're still facing it. Then the stress of once they got out of that, they had the stress of getting infected themselves. Then many people, the protocol of quarantine these healthcare workers for 14 days after also came very late. Still at many places it's not being done properly. So these doctors are either staying back in their hospital for another 14 days, or there have been arrangements made by the governments, various respective governments, to stay put in at hotels and all, but they can go home. So people who were frontline various doctors, They were like, doing duties they are doing duties for 14, say, continuous days, and then going for quarantine for another 14 days. So it's like, for a month, they are not in touch with their near and dear ones, which is actually, quite a traumatic emotional experience. Uh, so anxiety in doctors, was obviously thing. Then there was, then I would say, then I would talk about, the doctors who were actually not on the front line, like, they say a super specialist, say like me, or say other people who are not, doing the main work. They are not frontline warriors as such. So they're not, catering to the critical area zone. They're not in the ER. They're not in the, in the ICUs. So for them, it was no less a, problem, because the work was, almost gone away, because only COVID work is being done, and most of these surgeries, or say, patients were scared to come to the hospital. All, non-emergent emergency surgical work was postponed for a later day. So, most of the, doctors who were not working in the COVID zones actually were, sitting at home, working for, wondering, what will happen to the salaries. Salaries were slashed, obviously, then, all these, bombardment of Zoom meetings all around. So, they themselves had a lot of anxiety to, face. And then, they had this anxiety to protect themselves and, protect their patients. Even patients, doctors who are doing OPD, say, like when I am doing OPD, or say any other patient who is sort of, not in the, hot spot areas, but still, because by the nature of this COVID, which is, most of the patients, 80% are asymptomatic patients. So recently, some advisory has come out saying that, most of the asymptomatic patients do not spread, but, the tests and all are, proving that they may actually, have a tendency to spread. So basically, you are always on the guard. You have put on all your gloves, and you have to put on these masks, and then you have to maintain a distance from your patient is coming all, scared. He's, shoving his, prescription to you. You are scared whether this prescription is having some COVID. Very weird situation. We as doctors, especially in India, we have never, faced this peculiar situation of, social distancing, or I would say rather physical distancing from our patients. We are the most burdened people, from, if I compare from all rest of the world, or where doctors are treating patients, we are used to seeing a mob of patients, if we can put it that way. So suddenly this mob disappeared, and we were all, wondering what will happen of us. So those things were all happening. So now, what is the future? Though this, when I say future, it actually, encompasses the future of healthcare of India, as in how doctor treats the patients and patient treats the doctors, for say another, at least another an year at least, because all the studies have suggested that this COVID is here to stay, and we are still quite far away from actually trying to get a you know uh, any vaccine for it as if now. So as if now, it is social distancing, being careful, putting on your mask, being careful, and protecting yourself as much as possible from contracting COVID. So now, what are the challenges? So for us as doctors, we have to, again, obviously we have all started our OPDs. We have to, lives have to go back to normal. We cannot just be in a lockdown state perpetually. So, we have to start our OPDs. ER management has to be done. All things has to be done. So especially, in areas like stroke, wherein, time is brain. So, this aspect of it is very important, because here, we have a problem where, we have to rush and treat the patient. And now, because of the COVID, now, everything has sort of got diverted, as Dr. Ashish already, told that the attention is toward COVID. Emergencies are more toward looking COVID. We have to be protected. Even if we are seeing a patient of stroke, we need to put on all the, we have to go through all the barriers of, protocols, put on the hazmat suits and all that stuff. So the respective stroke associations of the world and India have come out with tweaked in advisories as to how to deal with this situation, how to cut down the protocols, and some people are innovative. People are trying to make some good hazmat suits, where you can don and doff very quickly, and so on and so forth. So, but the future lies in telemedicine, or what we call as video medicine. So, so now the IAN, the American Association of Neurology, Indian Academy of Neurology, they're frequently, giving out advisories, putting out small videos, and having these, lectures on updating on how to examine CNS, do CNS examination from a distance through a video call, how to triage these stroke patients by telemedicine, do most of the things by telemedicine by a no-touch technique, and then do the last terminal thing by actually doing the intervention or whatever. So try and be as safe as possible. So then training the staff in the ICU how to deal with stroke care, especially in this COVID times. The ER had got some revised protocols as to how to triage these stroke patients. So there are a lot of innovative ways people are talking about how to make their OPDs safe, and how to put on PPEs which are safe, and so forth. So just to talk slightly about teleneurology, actually talking about teleradiology, telemedicine. So telemedicine has been a rage, and it has established itself in probably most of the western part of the world, but we had sort of been sort of lingering on it for a very long time. But just when the COVID came and the necessity of social distancing, or what we call physical distancing, was realized, then immediately the almost this the law on telemedicine was being sat upon for the last 10 years. So but the government realized that this is an impending thing and it needs to be quickly done. So finally the telemedicine law has been passed. So that's a huge relief. And now the future lies in teleneurology, especially vis-a-vis at least another 1 year. We have to try and keep our patients safe as well as keep ourselves safe. So we need to make this history of examination, all these things very we should try and do it through telemedicine. So just a visual impression of how it's done. Telestroke, so you can assess the patient, triage the patient. You can you can guide your colleague who is in the ICU with all the things, all the investigations, as in all the images can directly be seen by a radiologist, and those images can actually go and transfer to the doctor, the neurologist, through a PAC system. So examination can be done somebody sitting in the ER, and the things can be the scores can be told to the doctor there. So it's like we need to try and be efficient as much as possible, but at the same time try and see as much as we do it with the no touch technique. So that's how it is. And also teleneurology has the potential to reach to a huge number of patients. That's so, so even if we don't have COVID times, this telemedicine has to flourish in India, because we are a population where very less number of specialists, and most of the super specialists are actually concentrated in the in the metropolitan cities, or the grade 1 cities, whereas a lot of poor patients, and almost 80% of the population doesn't have the access to at least the specialist healthcare. So this is something which probably is, if I say something which where in adversity you find some good things. So this is probably one thing which should be promoted in future. So telemedicine is actually the use of telematics, where an integration of telecommunications with computers and the knowledge of medicine. So this is a classic picture of what we were used to. This is how most of the doctors, not in, I would say, not in the metropolitan, but most of the second tier cities or PHCs or villages. So he's a happy doctor, and these are his happy patients. They're all surrounding him, and it was more of a community medicine kind of thing. But this has to change. So now the new normal has to be something like this, where you have to have an OPD. The doctors has to be in proper PPEs, masks. The patients has to be in masks. There has to be a social distancing. The prescriptions has to be carefully the to and fro of prescriptions, investigations, all things has to be totally managed properly. The timings of the patient's appointments has to be managed, and even the OPD, you see, as I'm showing this picture wherein they have marked these OPD spaces, wherein the chairs are put at a social distancing kind of thing. So this is probably going to be the new normal, at least for another 1.5 years. So thanks all, and let's all pray that this fury of the COVID pandemic wanes off and we get a vaccine or develop herd immunity, whichever comes sooner in future. Thank you.
Thank you, Dr. Amit, for your talk and enumerating about the neurological complications, including strokes and neuropsychiatric disorders, telling in details. So now the house is open for the question answer session. There is one question which is from the house in asking about how to keep our heart healthy in pandemic environment and which food or grade diet is recommended. I think I'll direct it towards Dr. Ashish, that or one person from the audience wants to know how to keep our heart healthy in pandemic environment, not directly related with neurological complication, but wants to know this about.
Pardon me asking again, how to keep the heart healthy?
So actually, basically, yeah, heart healthy, because it's a neuro health webinar. Although
people with heart don't have to worry about brain.
and maybe having a good exercise.
I'm sorry, but the last time I decided on talking about heart or doing anything was in 1985 when I passed my exam. So I'm sorry, I'm not the right person.
Yeah, so but
a basic, it's a simple solution. I
think these things are quite, it's not a, but
common.
One thing I would definitely like to say is that, since it's all about corona, so I would say the brain is the corona of your system, as in that is the crown of your system, right? So if you have a good brain, wherein you keep a healthy brain, your heart is going to follow that, So for a healthy heart, the first thing is you should have a healthy brain. Rest of the things, do good exercise, do isometric exercise, walk at least for 45 minutes. Nowadays they say, you should have at least 10,000 steps. Nowadays you have these apps and where you can put it in your watch, you can count your steps. So at least half an hour, 45 minutes of walking, 10,000 steps, do some isometric exercises, yoga, meditation, all these things help. If you are, check your BP diet. So most common problem with, the heart is that, it gets degenerated because of obviously with age, whatever degeneration happens, you cannot revert that, right? But diabetes and hypertension, these are two things which are the most common cause which degenerates your heart vessels as well as your heart. So if you're a diabetic, keep a good check on your diabetes. If you're hypertensive, keep your good control on your hypertension, apart from other routine things, which is walking, having a good, as I said, keep your brain happy. I mean, that's the most important thing. The rest of the thing will follow. Good food means, food with antioxidants, fresh fruits, fresh vegetables. Don't eat, things with a lot of salt. Don't eat outside food. I mean, packaged food, all these things should be avoided. I think that's the general thing. Dr. Ashish is smiling. He should have answered it because he has the most healthy heart.
He's so particular. That's why I directed it, Dr. Ashish. He's so particular about taking care of his heart. So anyway,
well, if you insist,
that's how I think I would like.
If you insist, I will only say, and I will answer in Sanskrit. Ati sarvatra varjite, whether it is your brain or your heart, don't worry too much about it. But at the same time, keep your habits, dietary or otherwise, in moderation.
In moderation.
That's it.
That's what it is. So when we come to this as such neuro health webinar, exactly. So if I may ask Dr. Ashish, how have you dealt with this COVID-19 situation in your practice?
Dr. Neha, thank you for this, shall I say, question. But let me share with you that no consultant in my hospital, including Amit and yourself, have taken a day's leave. We were working Throughout the lockdown period, throughout the pandemic period, I have conducted as many patients who came, surgeries for as many patients as they demanded, or rather they needed. But at the same time, as I mentioned in my presentation, we have followed, and the hospital administration has provided all facilities for the patients and the healthcare workers, not just doctors, every possible precaution and care to perform the neurosurgical operation. And you will be pleased to know that not a single mortality has happened during this lockdown period, despite so many risk factors and problems and resource crunch and whatnot. Yes, I may have advised a patient with backache who's lying down at home in lockdown for 30 days to just start walking within the room, but that's about it. Anybody else who needed a neurosurgical operation got it at my place.
Thank you, Dr. Ashish, for letting us know that. Just only one question from Dr. Amit in brief, very brief, that as there has been concern about the risk in patients who are immunosuppressive drugs. So how does it relate with patient with neurological disorders on immunosuppressive drugs like myasthenia gravis or multiple sclerosis? Does it increase any kind of a risk, or has there been any different reports related with that?
Yeah, that's I think a very
patients have to
important
have more
question,
concern.
Yes, yes. So look, the diseases which require immunomodulation as such are serious diseases, and they are long-term diseases which which needs long-term treatment. As in, say, as you rightly mentioned, myasthenia gravis, or say chronic inflammatory demyelinating polyradicular neuropathy, or immune-mediated encephalopathies, or immune-mediated diseases like multiple sclerosis for that matter. So basically, all the diseases which require immunomodulation, they are all serious diseases, and abruptly stopping medications in between can be more harmful than actually having the risk of getting any corona infection. But having said that, I am not saying that corona needs to be sort of not given that much of respect. But the thing is, you have to, the risk and the benefit, if you weigh between the both, the advisory is that continue with your immunomodulating medications. Though yes, these medications do tend to reduce your immunity to a certain extent, but what you have to do best is continue with your immunomodulation, and at the same time, so the patients who are on immunomodulation are what we call as the vulnerable population during COVID. So people, elderly people, diabetic patient, hypertension, and patients who are on immunomodulation, long-term immunomodulation, say on steroids or say Immunoran or whatever, they are also vulnerable population. So they need to be well protected. They need to be using the whatever masks, and preferably be at home and isolate themselves. But stopping medications is actually going to be very dangerous. So need to continue the medication.
Did Dr. Ashish, did you want to say something? I thought probably you wanted to say something.
I wanted to share something with all of us, all of you, and including I would like a comment from Dr. Amit. See, one of the mechanisms which is causing mortality or extreme sickness in corona patients is what is called as a cytokine storm. Sudden release of certain chemicals which causes the patient to suffer adversely, and the result can be quite poor, or it can land in. Now the cytokine storm has been treated with steroids. In fact, now it is coming out that it is the proper treatment. So while in my presentation I said that most of the neurosurgery patients will require surgery, especially after intracranial surgery, in a way, steroids might actually be helping, though they are not prophylactic. I'm not the physician. Probably Dr. Amit can elaborate better.
Yeah. So this is a very interesting question. So if I can explain it this way. It is like so the corona infection can be divided into two parts. One is you get an infection when your the resistance barrier is low, right? So which is basically when it goes through the nasal mucosa, and it breaches the mucosa, and it sticks to the ACE receptors, ACE receptors, and through that it breaks and gets into the system. So here comes the role of people who are of low immunity. people who are of low immunity in general, this breach of their immune system will happen and corona will overwhelm them and get into the system, get into the blood and all that, right? This cytokine storm is actually the late stage wherein patients, and this is which happens in 10 to 15% of patients. So the cytokine storm is supposed to be one of the mechanisms which actually pushes the patient down in the path of sickness, right? But there are 80% of patients who do not have any problem, but these 80% patients, the group of vulnerable population are those who are immunocompromised. So कहने का मतलब अगर आप इम्यूनो कॉम्प्रोमाइज्ड हो तो आपने अपना मेन गेट का दरवाजा खोल रखा है कि कोरोना आ जाएगा, ठीक है? जब आ जाएगा तो सेकंड स्टेज इज वो जो 10% पेशेंट में करेगा, which is the it will go through the cascading thing. And as very rightly Dr. Ashish said that there has been a lot of study as to how to, so steroid was also one of the treatment modality, but then the steroid is given at a low dose steroids, pulse steroid, that what they are talking about. And there also they are saying that we should, the best results are seen in patients who we are able to identify that this patient is going to have a cytokine storm. It's not that every patient will have it, right? So what they're saying is, if we are able to develop certain blood markers, say they are saying TNF, some interleukins and all that, if we test those and they are, so ferritin levels high, so whatever, so if we have got some markers which can tell us that okay, this patient of corona will land up with a cytokine storm, in those patients, if we are able to preempt that these are the patients, then in those patients we can give steroids or immunomodulation. So that would be the ideal situation.
Okay, thank you, Dr. Amit. And I think now with this, we come to the end of this webinar today.
One small comment, Dr. Neha, before we leave.
No problem. Yes, any
I
comments?
just want to let the public in general know that so far, undergoing neurosurgery treatment, no patient has had corona-related deaths, but a neurosurgeon has died because of corona. So neurosurgery treatment remains safe, albeit for the patient. The surgeon has to be careful. Thank you.
Okay, so now we
very aptly said, yeah. A
very
lot of
aptly
doctors
said,
are dying,
yes.
a lot of healthcare workers are dying. That's really something to
Yes.
worry about.
Yes, so we
Okay,
come
thanks. Yeah,
come to the end of the session. So I thank all my speaker, Dr. Ashish, Dr. Amit, also Ms. Payal. And at the same time, I would say the take-home message is that although we have to be cautious but not afraid to come and seek the medical help when it is required, and we basically remembering about neuro complications, and as it is said yesterday also and today also, the early seeking medical help in case of a stroke is very important, remembering the mnemonic of FAST, and also recognizing all the symptoms early as it's been told by Dr. Amit, and also keeping in mind that we are keeping our environment safe, so one should not be afraid in seeking the help early. Thank you, and once again I thank all the backend team also, and thank you.
Thank you.
Thank you.
Thank you.